Hello, everyone. Thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, you have... Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director.
Thank you, Mark. It's good to be with everybody here. We're excited to be... Good evening, everyone. It's good to be with you, or afternoon, or wherever it is for you. It's good to be with you here today. We're excited to be here for this keynote address and also for our awards session. We're especially thankful for our sponsor, the Human Services Research Institute, or HSRI, and we're pleased to have their support for the conference in general and for this session in particular. Human Services Research Institute has been a big believer in the concept of connecting data with policy, and today is no exception, and they're showing it with their support. With that, I'd like to bring to the stage Kevin McAvey, and who will be the moderator for the rest of the session today. Kevin?
Okay, good afternoon, everybody. It's so nice to talk to so many of you. I wish I could actually see you as I talk into the void here, but I know you're out there. Because I've worked with hundreds of you shoulder to shoulder over the past year. An astounding 18 months the past year has been, as it's really demonstrated the power and importance of possessing meaningful, usable health data. And it's a privilege to open our opening day keynote and award session for NAUTO's 36th annual conference. The theme of our conference, Rising to the Challenge, Connecting Data with Policy, could also not be a more fitting theme to capture the contributions our keynote speaker today, Jay Want, has and continue to make to our health data field, and for which he's being recognized today with NAUTO's Data Pioneer Award, an award given to an individual who makes distinctive contributions to data use and or programming. And Jay is a personal inspiration to me, and always brings an incredibly practical lens to resolving so many health data issues, challenges that we face day to day, and certainly the bigger challenges we faced over the past year as we all work together through our public health emergency. Jay Want, Dr. Jay Want, for those who don't know him, is Executive Director of the Peterson Center on Healthcare. He leads the center's expanding portfolio of initiatives and grants to identify high-performance models of healthcare, validate their impact on quality and costs, and facilitate their adoption on a national scale. Really put another way, he helps find what works, and he helps bring it to more people to make a sizable, scalable impact on a system that desperately needs and requires change, and he uses data and information to do it. The Peterson Center on Healthcare itself is a nonprofit organization dedicated to making higher quality, more affordable healthcare a reality for Americans, and was established by the Peter G. Peterson Foundation. It works with stakeholders across this healthcare system and engages in grant-making partnerships and research. What makes Dr. Want so distinctive in his day-to-day actions and year-to-year leadership is the perspective, the rich, deep perspective he brings to the problems he often is seeking to solve. He has a background as a primary care physician, which grounds the center and its work in enabling physicians partnering with patients and care teams to transform healthcare delivery from within the system. He is formerly a chief medical officer and board chairman at the Center for Improving Value in Healthcare, one of our favorite members, among many favorites, Civic. Hi, Anna and team. Dr. Wand has also served as an innovation advisor for CMMI and was president and chief executive officer of an MSO, which is now part of the Medicare Shared Savings ACO program. He continues to make daily contributions to our healthcare landscape, and I can't think of a more deserving awardee of a Data Pioneer Award and a more intriguing keynote for our work and our times this year. So with that, I'd love to pass it over to Jay to deliver our opening keynote remarks, and we'll have some time for Q&A afterwards. So thank you, Jay, for joining us.
Well, thank you for having me, and thank you for the award. I just want to say, first of all, I'm very grateful for the recognition, but I don't think you guys all know this because you work in this field. No one person ever puts up an ABCD. So I have to acknowledge the team at Civic, the current one, but also the founders who came before, Dory Beester and Phil Kalin, Edie Sun, Alice Louise Bonacker, all the people who basically turned an idea that the governor had into something that is incredibly usable today and I think impactful. So I'm really thrilled basically to accept it on their behalf. I'm going to share my screen and going to talk about the core question, which is, I understand the conference title is Linking Data and Policy, Why Does It Matter? And so I'm going to try to answer that question, hopefully in like 20 minutes or less. So why should we be linking data and policy, and how does that actually help scale APCDs? So as Kevin said, the Peterson Center in Healthcare is a part of the Peter G. Peterson Foundation. Peter G. Peterson being the guy in the pink tie in the foreground in this picture, who unfortunately passed away in 2018. The guy in the background is Michael Peterson, his son, and the current chairman and CEO of the foundation and of the center, and therefore my boss. So Pete, incredibly successful guy who was Secretary of Commerce, and then went on to found a company called Blackstone, whose interest he sold in 2008 for $1.9 billion. He devoted about half that money to the foundation to try to preserve what he saw as the American dream. I mean, he's a kid standing on a stool in his parents' all-night diner in Kearney, Nebraska at age 8, making change out of the cash register, and he rose to this level of success. And he worried basically that with the amount of deficit spending that the country was doing, that dream wouldn't be available to future generations. So he founded the foundation basically to try to address that problem. Now, in a story that I always tell, which is almost certainly apocryphal because I wasn't there, he sends off his analysts to find out what the problem is. And they come trotting back and say, we got good news and we got bad news. I mean, the good news is that we found your problem. The bad news is that it's healthcare. Now, we calculate about 3/4 of the indebtedness of the federal government over the next 20 years is going to be related to spending on healthcare. And therefore, if you want to fix the federal deficit problem, you're going to have to fix healthcare because nothing else really matters. Pretty sobering message, but we set about to try to do that. Center was founded in 2014 then with a couple of different foci. One is delivery system reform. We've spent probably our first 2 or 3 years trying to scale a primary care model, much like the patient-centered medical home, in order to be able to transform American healthcare. And we've learned a bunch of lessons doing that I'll share with you during this talk. We spent more time in the past few years on the second bucket, originally called fostering an environment for improvement. So this includes data, trying to create functional markets, empowering purchasers, and using regulation where necessary in order to be able to affect that result. So those are the two things that the center really tries to impact in its life. And this basically was the whole thought that, boy, in order to be able to cover everybody comprehensively, you got to lower the cost of the activity in general. So reducing the cost of healthcare while maintaining or improving quality and patient experience is really what we do at the center. So in the course of the primary care work, we figured out basically that there are kind of three big ways that little things become big. Because that was the whole idea, right? Find an idea that works and then basically scale it up so that it applies not to just one instance, but thousands of instances across the country. So we did some kind of book learning to try to figure that out. And we basically boiled it down to three things, which are a number that I can remember fairly easily. So it was basically this. It comes down to markets and mandates. Movements being individual effort, markets being forces, and mandates being largely government. So let me walk through each one of those and also talk about how APCDs apply in each one of those areas. In movements, the motivation is really, it's just the right thing to do, or more to the point, it's the wrong thing not to do this. It's driven by volunteers basically donating dozens and sometimes hundreds of hours in order to be able to make things happen. Examples would be the anti-apartheid boycott in the 90s, and then fast food boycotts so that the United Farm Workers under Cesar Chavez could get a decent wage, 50 cents more for a pound of tomatoes. That's all we're talking about. People boycotted fast food chains until they actually agreed to negotiate with the UFC. In APCD land, I think the pitch would be, well, there are these wild prices, but so what? Well, it's unfair. It's unfair because the people who can afford it the least, the uninsured, people paying cash, oftentimes pay the highest prices, and no one seems to realize that. If you're kind of trying to get this to happen as a movement. Markets are basically how this country. I mean, basically, it's something that's worth paying for because you either make more money than you spend. It's revenue. So any successful model for this. If you're doing as an APCD, you're basically saying, listen, with this transparent data, you're going to be able to purchase more effectively, so you're going to save more money than you spend supporting the APCD, and therefore you. And then finally, mandates. Mandates are a social motivation for the good of the group. It's driven by government, and an example would be child car seats, which kind of state by state after people figured out that it really did save lives. So in the case of APCDs, and a small but growing number of states are actually starting to articulate this, high healthcare prices actually threaten the state's economy. No kidding, we're talking about small. We're talking about something that makes employers not located in our state because they can't afford basically to insure their employees and dependents for healthcare. So prices should be transparent so that we can sustain the state and its economy for the long run. Well, mileage may vary. Each state is different, and so I'm going to talk about basically what the central question should be if you're trying to invoke each one of these motivations. If it's a movement, you have to ask yourself, in my state, how deeply do people feel that data availability and transparency is a moral, i.e., it just isn't fair. I mean, you just can't have this and have a society that can look itself in the mirror and feel good about what it sees. If you're trying to invoke market, you're basically saying, I'm going to be able to package my data in such a way that so many people will want it that will actually be able to kind of cash flow this thing the way you would kind of a private company. And that I can find enough purchasers, a big enough market actually going to be able to justify the multi-million-dollar cost of building and maintaining one of these. And then finally, mandates. This is going to depend basically on, is your state relatively bluish or purplish or reddish? What is the willingness of government to mandate for social goods? I mean, that's kind of a political philosophy thing, and it'll be different in different states in the union. And so you kind of have to ask, what is it like in my state? What is the likelihood that people are willing to use the power of the state in order to be able to create a good that would apply to everybody? So if we had like a fancy polling thing, like I see in some conferences, I'd ask you to push a button at this point and vote for which one you like. You don't have that, and so just keep your answer in your head as I go to the next slide. These are my answers, and your mileage is you're in different places. But for me, in terms of movements, there isn't really a good bumper sticker for APCD. 30 to 60-second rationale you can try it out there on a TV spot or while you're stuck in an elevator with somebody and tell them why an APCD is such a moral thing to do. I think most of the people who would do that are actually on this call at this point. And unfortunately, there aren't enough of us in order to be able to drive this to conclusion. And so while movements are good for many things, it has to basically grab people's emotional attention in a very short period of time and compel them to take action. And those are pretty few and far between. For a market, markets are kind of mixed in my view. There are some employers for whom this really speaks to them. In my experience, it is a subset of the larger employer market in that it's employers generally that are large enough to have the expertise to be able to judge this. They also tend to have low-wage workers, and they also have to have relatively tight margins. Those last two things are really important because if you can just raise your prices and cover the cost of a 15% increase in your insurance premiums, you generally do that because it's a fair deal when you have to change your insurance plan or your network or whatever. It's a tough deal, and so most employers don't have that kind of urgency. The ones who do have a constraint. Governments, we kind of like governments, but we like them especially at the state level because states have big budgets, but also have big constraints. And so, they can't print their own money. And so states have to increasingly purchase better and better in order to be able to cover their state employees, their Medicaid populations, and sometimes others that they're responsible for at the state level. And then finally, mandates, again, it depends on that kind of spectrum from blue to red about whether people are actually willing to do it. It's politically difficult, but some leading states are actually engaged in creating mandates in order to be able to make this happen in a way that becomes a law. So how did I get to those conclusions? I'm just going to review briefly kind of the thinking, so hopefully explains how maybe your mileage may differ on this. These are important things that we learned. One is the first point that I made before, which is there are only a minority of purchasers, payers, and providers who care to purchase effectively. That's a really tough message because our whole area, our whole industry here is really built on the thought that people want to compare prices and they want to compare value in order to be able to make their dollars go further. But because of what I just said about purchasers, there aren't that many of them that are interested in doing that. Payers oftentimes also have leeway basically to continue to raise their prices. And so they aren't actually terrifically motivated to make this distinctions between the providers and the network. And then the providers that I found that are actually willing and able to do this are usually risk-bearing. They're people who basically get a fixed budget for a set population at the beginning of the year. And if they overspend, then next year is not that much fun. And so if you can actually target these particular subgroups, I think that that's an important thing because, as I've been saying for a while, being out of money does have this amazing clarifying effect on thinking, makes you make tough choices. And that leads to the third thing, which is what we at the center call the theory of constraints. Work only with those entities that have a fixed budget for healthcare and need to care for an entire population without any leeway to do it a different way. So if you accept the premises that I just put out, then what you're looking for in terms of what you produce as an APCD is extraordinary product market fit. Product market fit is a concept that was, I think, first articulated by Mark Andreessen, who, in fact, as opposed to Al Gore, actually did invent the internet at U of I, and actually is now a venture capitalist at Andreessen Horowitz, or A16Z in Silicon Valley. He basically said, you're looking for product market fit. It's like the key to life because, one, you're basically trying to find a market big enough in order to be able to sustain your business. And if the best of all possible worlds, it's a growing business so that its demand continues to increase. And you have been so good at your job that you've built your product basically to meet the needs of those customers as their needs grow. That's perfect product market fit if you can actually do that. So accepting all that as a premise, then if you accept that, then the government mandate and or government as a purchaser, they're the essential APCD customer. They're the people who actually have a large enough market, which is growing at this point, that they're the people that you need to speak to. Whether you like selling to government or not, it is the essential customer, in my view, for almost all APCDs. So whether as a purchaser or as a regulator, government is often the only actor with enough sustained interest in effective purchasing to support APCDs in the long run. I speak a little bit from personal experience, and Anna can talk to you about this as well. we tried really hard, basically, at Civic in Colorado to do number two, actually make large enough private purchasers that it was self-sustaining. It ultimately was a gap that was just too hard to fill, and we entered into the general budget for a certain amount of money for the state of Colorado in the long run, which is a nice place to be at this point, quite frankly. But we did test the hypothesis, and at least for us, didn't come up with an enterprise that could be sustained purely through commercial interest. And that means, again, achieving product market fit with your most important customer. It means knowing what the governor wants. It means knowing what the DOI wants. It means knowing what your state legislators want. And so the deeper your relationships and the better understanding you have of those leading constituents' needs and their points of pain is what is going to help you most define the use cases that will make your APCD sustainable in the long run. So I'll close with this and then answer a few questions as long as my battery holds out. This is a quote that is attributed to Winston Churchill, and looking up for this talk, apparently he may or may not have said this, but he's often quoted as saying, you know, Americans will always do the right thing after exhausting all the other alternatives. Half joking, his mother was American, and so he's only half joking about that. But you know, I think we've tried basically on the movement side. Those of us who were working on this 15 years ago thought this was a movement, thought this was something that had such great potential to fix American healthcare that it was simply a moral thing to do, to work on providing data to purchasers in a way that they were going to be able to purchase better and extract better value from healthcare for all of us. Didn't exactly work out that way, although there's still some drive from that particular engine. We tried to do a pure market play in lots of places just to see if you could sell enough data, but you know there are problems with markets that you know for this particular kind of data the demand may be episodic, and unfortunately one of the best kind of customers for this other than government is usually academia, and then we figured out very quickly at Civic that the academics don't have much money. Very hard to charge them $50,000 or $100,000 for data because it's generally not in their study budgets. So that leaves us basically with a combination of government as a purchaser to create a market and government as a regulator. Those two together, I think, is kind of the winning thing in the long run, and therefore, you know, I might suggest that your best move after leaving this conference is to call up your local legislator, your Senate Majority Leader, your Commissioner of Insurance, and sit down and ask them to lunch and ask them what they need from your APCD in order to be able to make their lives and their jobs good and maximally efficient. And with that, I will thank you for your kind attention. Thank you for the award, and I'll be happy to take a few questions if that's helpful. Thanks a lot.
Terrific. So as questions roll in, I think we have one certainly off the top of my head, like the Peterson Center, like how are you presently pursuing some of the goals and the mission as you've described it, influencing the market in positive ways, really elevating APCDs as the resource that they promise they could be?
I'll spend a few minutes talking about some work that we're doing at the state level. So many of you some of you may be aware, we have a project with the Lundberg Memorial Fund looking at trying to create total cost of care limits or caps, kind of modeled after Massachusetts and Rhode Island, where we've done some work. So basically establish the limit, create the constraints basically that we talked about in the theory of constraints so that people are now motivated basically to find value. Second, beef up the ability of the APCDs to provide data, and then the analytic ability on top of that in order to be able to create reports that point out where there might be market inefficiencies. Why am I paying 50% more than my multi-state comparator average for a particular service? What is the concentration of my providers relative to a state that looks a lot like me in terms of population and geography? That kind of comparative data we think can help people drive toward improving their value in a way that's sustainable, not only for the state, but for the underlying providers and purchasers as well. So the combination of the information, the analysis, and the constraint, the target, all three together, is our current theory about how we best enable governments and states to maximize their value in healthcare. We're also interested in employer coalitions. There have been a few that have popped up around the country that are, a few of them are independent of government, but many of them are working in partnership with government in order to be able to say, hey, you're a purchaser, I'm a purchaser too, we have the same providers, why don't we all try to figure out a way to enable to change our law to enable us basically to purchase together in a coherent way, which again makes it sustainable for us and makes it sustainable for our providers who provide an essential service for the community. So that increase in purchaser power, purchaser aggregation enabled by regulation and legislation, we think is the admittedly tough road to hoe, but it's the best one we could see right now.
Yeah, and I one of the points that you mentioned, and the important stuff that we've learned, being out of money does have a really amazing clarifying effect. And I remember this from like my college days, and now with a kid, like I face it every day. and like I think states face that too as they kind of think about their budgets.
Yeah.
But I'm also coming back to this theme of the Peterson Foundation and achieving the American dream, and potentially, at least on the federal level, being overextended and being able to kind of spend beyond the means. Like, how should we be really thinking about healthcare costs and investments in data when and boundaries when those boundaries don't always apply to every actor in the ecosystem?
Wow, that's such a great question. Because the problem is that we have worked for many decades at this point to make sure that we don't feel the consequences of overspending in healthcare by passing the cost on to future generations or to at least somebody else in the room. I mean, if I'm a payer, well then I'll just pass it on to the employers, and if I'm an employer, well I'll just pass it on to the employees, or we just keep passing the buck, kind of one seat to the left until we're out of seats, and we're getting pretty close to being out of seats. I think that's why government does have to establish these kind of total cost of care caps, because otherwise it's really hard. And what we learned in Rhode Island when this happened, when they established that, what it allowed was for the payers to go back to the providers and say, I love you guys. You guys do such great work for us, and the state just won't let me pay what you asked of me. So let's talk about a realistic number that doesn't make your charge master go up by more than 2.3%. Let me give you a little bit more here, but let me hold everything else flat. It's kind of like that. He's kind of standing behind me as the government.
I can't do anything. It's him.
I can't do anything because I mean, that's kind of what the dynamic that's like, which everybody understands, but that's okay, because it is actually the reality. It's the alternative universe where we have infinite dollars to spend on healthcare, which is actually the illusion. And this is basically just kind of restoring people's sense of this. And to get back to the start of your question, I think we should think about healthcare the way anybody on a budget thinks, which is there are tough choices to be made here. And I'm going to try to, as government and as an employer, as a purchaser, I'm going to try to make the best choices I can for everybody. Kind of aggregate, which means that there's got to be a little give and take in what we do and what we don't do. Because if you only have a certain number of dollars, you have to try to create the greatest good for the greatest number of people. At least you do if you're government. So so that's the way I think we should think about it. Not as kind of, boy, some mean person in a back room is trying to keep me from getting stuff, but that I'm trying to create the most good with a limited number of dollars.
Yeah, and I really love that idea of state healthcare cost growth benchmarking program. That's kind of being a disruptor to the commons problem, where everyone else can point to everyone else. At least it draws a line in the sand for everyone to focus on and be held accountable to. That's really interesting. We do have a question from Sylvia. Hi Sylvia. Jay, do you see much hope for data activists and Department of Labor in reversing the impact of Go Bay? And of course, this is speaking to kind of the data completeness issues and APCDs. And as we think about data as a public good and states as stewards of them, I think it also raises the role of like the national role of data stewardship here, and what we can do to kind of make sure everyone has the information they need.
Yeah, okay, so I'm going to try to be brief on this because this is it's a wonderful question and with a very complicated answer. In fact, there's so many of those simple questions with really complex answers. So one, do I see much hope? I do see hope. I do think that over time, we will see movement toward the DOL actually becoming activated to, Gobea basically says, well, the states do not have jurisdiction over this, over the provision of data into state APCDs. And who has that jurisdiction? It's actually the DOL. I think it will take a number of years and probably a couple different administrations before that actually happens. I do see some hope actually in recent Supreme Court rulings, basically limiting the span of control for ERISA. I mean, I think ERISA is being chipped back a little bit year by year, and I think at a certain point it'll be enough that people will say, okay, then DOL should step in at this point and mandate a standard for data formats or whatever that essentially allow us to compel ERISA accepted employers to put data in a format, I mean, in their defense, in a standardized format, which does not make them comply with 50 different standards.
It was a great question. Thanks for your response. So one question we have from Priscilla, and then we can close with Anna. Priscilla asks, about the values of empowering individuals with their own health data. I think in the past few years, CMS and ONC have taken steps forward with the interoperability rules to really require plans and providers to make sure that individuals, when they want it, can get data for themselves or have it be accessed by a third party. Like, how do you see that playing into kind of the future of data exchange, data use, aligning or not aligning with the center's goals and objectives?
Yeah. Okay. So I'll give you what I think are the good and the bad of that. The good of it is that I think the macro kind of sweep of history through the 20th and the 21st century is individual empowerment. I mean, essentially that is it's almost the state religion at this point, right? I mean, basically things that are good for individual empowerment are generally things that politicians get behind and that have legs, basically, in state houses and in Congress. The bad news is that part of the imperfection of healthcare and healthcare data as a market is the episodic nature of the demand. So basically, by the time you need basically to be able to push one button to have everything drop into your iPhone and then sorted through and synthesized by a third party, it's usually pretty late in the game. I mean, you realize that you have a serious diagnosis or whatever, and so it's very difficult at that point to gather enough agency in order to be able to do that. Mm-hmm. So while I do think it's a very powerful force in healthcare data, it is one that's hard to mobilize and aggregate before there's an actual need, and that's why I mean, you can tell from my presentation, there's a bias for me that the government should actually act on people's behalf for a need that they won't know that they have for hopefully for a good long time.
Amen. Thank you, Jay, and thank you for the question, Priscilla. And to close us up appropriately with a question from Anna, not only through Civic but nationally, you do carry the message and value of APCDs. And a question for you, and then I'll pepper in my own anecdote here. Like, how do we engage more states, legislators, policymakers to utilize their state APCDs in policy? And I just want to note that I did work with one set of state policymakers, and I won't name the state. They were pontificating like about how wonderful it would be if we just had this centralized data resource that we could use to answer this question. And I'm like, you do. And I think that goes to Anna's question about making those connections, both like systemically as well as kind of raising awareness even within states about the value and promise of APCDs.
Yeah, I I wasn't kidding about calling your legislators up and asking them to lunch. This is one of those deals, right? I mean, because those people are used to being assailed from every different direction by special interests, right? So actually having somebody who's willing to do something for them and not ask for, for example, additional funding for the state for the next long bill, I think is really important. I mean, for them to understand that, you, Anna, and others are in a position basically to make them heroes on some level. I mean, basically, what do they actually care about? There might be some, those legislators, in fact, there are probably a lot that don't have any interest in this, but any of them who have expressed they have an interest in healthcare and why is it so bad? And I get a letter, every other day from a constituent that's complaining about how high their premiums are. You should try to make those people heroes. We have advisors at the national level who say, every time somebody tries to move on this thing, there's this mobilization of people who don't like it, who are basically yelling at them. Wouldn't it be nice if somebody said something nice to them, like, you're really doing a wonderful public service for this. We have your back. We're actually willing to put out some, stories, publications, whatever, to endorse, to give you air cover that this is the right thing to do. And I've started to think in that way, is that this is about a long-term relationship with people who are going to make critical decisions, who actually need to understand that it's in their interest and that you're trying to help them do a good thing for the people of their state.
Yeah.
That long-term relationship, going with them, not with an ask in the first, lunch or the second or even the fifth, but to try to establish some trust that you're actually doing the right thing for the right reason.
Yeah, I really love that kind of proactive nature where like APCD agencies and data agencies we just tend to be more responsive because we have so much going on, but at least having like one eye to the horizon and where we're going.
Yeah, I think the Venn diagram of skills for being a data wonk, like many of us are, and sales is pretty low generally. But this really is about a long-term relationship, if you will, kind of a sale. And it's vitally important, basically, that we engage in it, that we get good at.
Excellent. Well, Jay, congratulations again for receiving the Data Pioneer Award, and thank you so much for delivering an important message in your keynote today and joining us for our annual conference. We really appreciate all that you do.
Great. Thank you so much, and thank you so much for having me. It's been a pleasure to be here. Hope you all have a great rest of your conference.
Thank
Talk
you.
to you soon. Bye-bye.
Over to you, Norm.
Hey, thank you, Kevin. Thank you, Jay. Fantastic message, fantastic opportunity for us to hear from you. We're so excited for Jay and for his good work. We are now going to proceed to the rest of our awards session. First, we're going to do the Elliot M. Stone Award. And for the Elliot M. Stone Award, I am going to turn the time over to Joe Thompson.
Hi, I'm Joe Thompson, President and CEO of the Arkansas Center for Health Improvement, and I'm honored to be joining you today for the annual conference of NADO. Since 1990, NADO has presented the NADO Award of Excellence in Health Data Leadership. Recipients have been individuals whose creative efforts have made outstanding contributions to improvements in the collection, application, and dissemination of health data. In 2005, the NADO board renamed its annual award, the Elliot M. Stone Award of Excellence in Health Data Leadership, in honor of Elliot Stone, a longtime NADO contributor, in acknowledgement of his generosity, care, and commitment to the field of data and health information. In 1974, Elliot created the first databases of the Massachusetts licensed healthcare professionals. Following leadership positions in state government advancing health information, he became executive director and CEO of the Massachusetts Health Data Consortium in 1978, which became a model for many efforts on which we work together today. This award recognizes significant contributions to the health information field and those who exhibit characteristics of quality, excellence, and passion in their work, characteristics that Elliot himself embodied. It is NADO's pleasure to present the 2021 Elliot M. Stone Award of Excellence in Health Data Leadership to Michael Lundberg, Executive Director of Virginia Health Information. I would like to recognize Kyle Russell, also from VHI, who made the nomination, to introduce Mr. Lundberg. Kyle?
Hey everyone, it is Kyle Russell with Virginia Health Information, and I'm sure you all are enjoying the 2021 NADO annual conference, and I appreciate just getting a couple minutes to talk about this year's Elliot Stone awardee, Michael Lundberg. And so I've had the great pleasure of working under Michael for the past 8 or so years, and I have the great honor, yet very difficult task of following Michael's footsteps to become the CEO of DHIN when he retires after just an incredible career later this year. So, when Michael started DHIN and has been with the organization since the very beginning, and things were a lot different than where they are now in 2021. When Michael started, there was no guaranteed funding, and there was a sunset clause in the organization, and we have just one program to support everything that we were doing. And if you compare that then to where we are now and what he's accomplished, it's pretty incredible. And if I were to really boil it down to what I think maybe his single biggest contribution is to, our community, it really is being this role model and the epitome of what it means to be a long-standing, stable leader that's achieved longevity within health data, an industry that isn't always the case. And so he's really just proven that you can do it, and I can't imagine someone doing a better job with from where they started to where they finished than what he's done. And I think that in working with him for a while, there's these key themes that longevity and success is built on that have served us very well, and I'm sure serve a lot of your organizations well as too. So one of which is certainly diversification, and so we've added so many different programs through the years. And if you look back at the hospital discharge database, which is the program that the DHIN was founded on, that's now about 5% of our revenue. So our pie chart has a lot more slices in it, and that's really made us a lot more resilient organization that can do a lot of different things. The next of which is collaboration. And Michael's always been very big on not competing with our state partners, with our other state peers, with vendors, everyone else. It's really, let's find a way to collaborate and work together and achieve more together than trying to compete and pick one another apart. And then the third would be innovation. I think with most of these different systems, Virginia is not traditionally the first state to launch something, but we're always one of the earliest states. We tend to be a pretty early adopter of some of these different systems. And so we're an early adopter, but I feel like we've always delivered. There's not been a flop in there. So we were early enough to make sure we were innovative, but we never got burned. We didn't take on too much risk. We learned how to do it right and then share those lessons with the community. And so, this award, no one deserves it more than you, Michael, for what you've achieved through the years. It really, you embody what it means to have for a lifetime achievement award in our field. And these projects can come and go, and they will, but your reputation stays with you forever. And I can't, I can only dream of ending my career, and I'm sure everyone listening to this now, of wrapping things up and having the reputation that you've built through the years with all of us. And so we're so happy for you, and we really look forward to celebrating your success and what you've achieved through the rest of the NATO conference. Thanks.
Good afternoon, and thank you, Kyle, and the rest for the honor in awarding me the Elliot Stone Award of Excellence in Health Data Leadership. I want to acknowledge the generosity, care, and diligence in the field that Elliot and all his colleagues gave him. He set the highest standards for his own performance and for others to follow. So this award is special to me for the reasons above, that this award caps my many years of service to NATO and DHI, the organizations that I'm retiring from at the end of October. We also owe the Arkansas Center for Health Improvement our thanks, as they are sponsoring this session. Again, many thanks to all of those that made this possible.
Congratulations, Michael. Well deserved and a great honor for you. At this time, we're just going to take a quick break, and we're going to get back to one more award presentation before we wrap up for the day to announce the winners of our day one drawing. So those of you who have been collecting tokens in the game so far, so today we did 2 drawings, one for everybody who was in the top 20, and also we did one for everybody. And the winner of the top 20 drawing is Erica Plant from University of New Hampshire. And the winner of the everybody drawing is Tracy Treasure from Comagine Health. So congratulations to Erica and Tracy. I'll be reaching out to you to make sure that you get those prizes. For the rest of you, you can see on the screen the token for this session, Lighthouse. You can enter now for a chance to win a prize tomorrow's day 2 drawing, or at the end of the conference for the grand prize drawing there. With that, I am going to now introduce or bring on stage Pat Merriweather-Argis for the presentation of the Innovation in Data Dissemination Awards. Pat?
Hi, I'm Pat Merriweather-Argis, a member of the NATO board. Since 2009, NATO has been honoring an organization with the Innovation in Data Dissemination Award. This award was instituted by the board of directors to recognize an organization that is effectively communicating with the public on health data, which we all know is critically important. Eligible organizations include government agencies, not-for-profit organizations, and for-profit companies. The types of innovations in data dissemination include social media, websites, advertising campaigns, reports, and a combination of. Congratulations to the 2021 award winner.
Good afternoon. I'm Jim Harrison, President and CEO of OnPoint Health Data. It's with great pleasure that I join you here today to present NADO's 2021 Innovation in Data Dissemination Award to the New England States Consortium Systems Organization, also known as NESCSO. In 2021, NESCSO announced the release of the New England States All-Payer Report on Primary Care Payments, a 6-state review of primary care investment based on APCD data that was, importantly, informed by key non-claims data. The report involved an extraordinary amount of cooperation and collaboration across many teams, as you can see from this slide. From NESCSO's leadership and the initiative's lead, Richard Slusky, staff in each of the 6 New England states, OnPoint's analytics team, and advisors and funders from Milbank Memorial Fund. The full project team worked through many challenges to develop a new and creative approach to combining multiple states' APCDs through this collaboration to achieve a broader understanding than could have been achieved by any one state on its own. NESCSO's distributed model provided transparent definitions and methodologies that allowed each state to consistently build summary data, provide comparable results, to advance a shared understanding of the amount of each state's investment in primary care. NESCSO's Primary Care Investment Work Group worked together with representatives from each New England state and was galvanized by recommendations from the Primary Care Collaborative and other organizations that a standardized measure of primary care investment was needed before they could demonstrate whether increased investment in primary care can lead to improved quality, increased access, and lower cost. The first step was to collaboratively develop a standard definition of primary care providers and services. NESCSO selected OnPoint Health Data to support the states. Using the distributed model, each state provided data directly from their APCD and non-claim sources, including alternative payment model data. Detailed specifications and quality checks were established to ensure accurate and complete results, with careful investigation of discrepancies. While the distributed model was resource intensive, it avoided any inherent limitations and delays associated with following each state's individual data release protocol. NESCSO's analysis ultimately reflects primary care payments associated with 7.2 million commercial, Medicaid, and Medicare members. Following the report's publication, several other states have adopted or are considering adopting its definitions. NESCSO's report is significant in its inclusion of the entire New England region and its use of standardized data and definitions of primary care providers and services. It provides a unique analysis of the level of primary care investment across 6 states, and importantly, provides a detailed blueprint for other states to follow in assessing regional and national investments in primary care using statewide APCDs. I'm honored to present this year's Innovation in Data Dissemination Award to the New England States Consortium Systems Organization. Congratulations.
Thank you so much, Jim, for that overview and for the nomination. And thank you very much to NADO for this award. I'd like to take this opportunity to publicly thank everyone on the work group, and specifically Richard Slusky, who I'm going to pass this on to next for some words about the effort. I do want to recognize Rachel Block. So Richard, thank you very much. This would not have happened without your diligence and commitment.
Thanks, Elena. I appreciate that. And this report took a lot of work from many, many people. And I just want to recognize representatives from the 6 New England states, from Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And also, we really couldn't have done this without the technical support from OnPoint Health Data. They were very helpful in helping us organize our processes for the collection of data and the reporting. And we have with us today Carl Finnison from OnPoint and Katie McGraves Lloyd. And we have Adrian Texador, who's with us today from Connecticut, who provided a great deal of advice to us as a state representative.
And Carl, would you like to say something?
Yeah, I just reiterate the thanks to the participants from the 6 New England states.
Great. So thank you again to NADO. If folks would like to see the report, please go to the NESCSO website, NESCSO.org. Thanks again.
As the Executive Director of NADO, it is my pleasure to announce the awarding of the Innovation in Data Dissemination Award to the Delaware Health Information Network, or DHIN. DHIN has developed a number of channels for disseminating data that are crucial to the health and well-being of its customer base of patients, providers, and public health personnel. For patients, the DHIN disseminates data through its Health Check Connect personal health record. The Health Check Connect PHR is on their website and is also available in native mobile app form for Apple iOS devices and devices that run the Android operating system. The Health Check Connect offers a number of services to patients, including digital consent management, lab and test results, and direct secure messaging. Of these services, digital consent management and test results offer recent examples of innovation in data dissemination that may be useful to share with the broader healthcare community. This innovative approach allows data to be used and transparent from all government agencies, providers, and end users when applicable. Congratulations to Jan Lee and all our friends at the Delaware Health Information Network.
I'm very honored on behalf of DHIN and all the people who worked hard on this project to accept this very prestigious award from NADO. We never dreamed when we started the work on the personal health record that we would get the kind of acceptance that we have gotten. But I'm really proud that today we have approaching 19,000 enrolled patients, and it continues to grow every month. So we're grateful that we found a use case that drove uptake, and we would be very glad to share our experience with others who may contemplate doing the same thing in your own jurisdiction. Thank you very much to NADO for this award. I wish everybody who had been a part of working on this project could be here with me to accept it on behalf of DHIN.
Well, thank you everyone who participated in the nomination review presentation of these awards. Congratulations to Jay and Michael, also to DHIN and NESCSO. We have 2 more awards which will be presented on Wednesday during our open plenary to the 2021 NADO Rising Stars, a new award this year. And we hope you will join us for that as well. At this point, we're going to take a 5-minute break and invite everybody to join us in one of the virtual mocktail rooms. I'm going to be making my favorite mocktail. It's called High in the Sky. Maybe you've seen it before, maybe you haven't. But come on over. If you don't have the stuff to make it, that's okay. Just bring whatever you've got. If you've got nothing else, bring a bottle of Dasani. And we'll just have a great time talking there. Charles will be in his room. We've also got Jen Toms, and we've got our friends from Kentucky who are going to be doing a mock mint julep. So find a place, find some friends, and we'll see you all over there. Thank you very much.